Alright, here we go. So, yeah, as you can imagine, the disease susceptibility of like neuro disorders, multifactorial. There's a lot of different factors that weigh into this, right? It could be, in the embryo or the fetus, okay? It could be from exposure to a pathogen, toxin, damage, whatever. Now, let's let's deeply talk about strokes. So another word for stroke that you'll see on your exam, this probably isn't new to you, is a cerebrovascular accident. Makes sense, right? So, or a brain attack, which I think is cheesy, but perhaps. But blood supplies to the areas of the brain are interrupted, okay? So, they're showing you here that a blood clot can get lodged in a cerebral artery. How could that happen? There's a disorder, arrhythmia. AFib, right? Top of the heart's quivering, and then it busts a clot loose, and it'll go up to the brain. Another way is plaque, all right? This is like a thrombus. So just like in the heart and the coronary arteries, how the, atherosclerosis, same thing can happen in the carotids and up in the head, okay? And then another way, this is a typical carotid artery, but I want to show you, it's coming this. We're going to go backwards, but a cerebral aneurysm, right? So you can have ballooning of a cerebral vessel, and if that puppy pops, what happens? Hemorrhagic stroke, right? So just be aware, there's different ways strokes can happen. But of course, the treatment goals is we have to recognize a stroke, and we have to rapidly intervene and take them to the appropriate hospital. That's the most difficult part. I've written 2 papers on that. Both of them are published. And then time is brain, okay? So just be generally aware. This is straight out of my medical textbook. It's pretty consolidated stroke information that may or may not be helpful to you, but it talks about the different types of strokes, okay? Now, moving forward. Strokes can happen for different reasons, but as you can imagine, let's go to this one first. If there's a clot here, distal to the clot, the area dies, okay? If there's a ruptured vessel here, distal to the ruptured vessel, the area dies. Makes sense. When that area dies or infarcts or is ischemic, it produces a predictable set of signs and symptoms, and we can kind of guess where the infarct's at, okay? Now, the onset could be sudden or gradual, when your book's obsessed with that, and we're going to talk about what that looks like here in a minute. But let's first talk about an aneurysm. So aneurysms, just a straight up aneurysm is a ballooning of a vessel, but these can pop, and then that's when the bleeding can take place. So, that's pretty much what you need to know. Is they can pop, and this can cause bleeding in different areas. That's what we need. I don't want to go any further on that. Makes sense, right? Yeah. Balloon pops, stroke, hemorrhagic stroke. Now, here's what they want you to know. Your book is obsessed with this, but I actually think it's kind of helpful as a paramedic. With a hemorrhagic stroke, the orange line, when you start bleeding in your cranial vault, pressure is going to continue to build until you die, right? Or it's fixed. And that's what they want you to know. From the onset of symptoms, the symptoms will get worse and worse and worse and worse and worse and worse, and you will eventually die. Makes sense, because pressure goes up, 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 and it's not just a confined area that's getting affected by that pressure anymore, it starts spreading. Makes sense, right? Compared to an ischemic stroke, what happens in this is your area gets ischemic and your symptoms get worse and worse, and then it infarcts and it's just bad. Right? It just stays, you're just going to stay with left-sided hemiparesis, right? It just stays that way. Now, that's what they're talking about here. This area, it just dies. But if you start bleeding and now the whole brain's starting to get pushed on, your symptoms will get worse and worse and worse. Makes sense, right? Mm-hmm. So they are obsessed with this table, and I actually think it's pretty helpful, okay? So just be aware. Now, an ischemic stroke, this is caused by an occlusion. A clot busting off, a thrombus, something to that effect, okay? And again, of course, the severity can be dictated by the artery that's involved. Is it a large vessel? Is it a small vessel? Where is it located within the brain? Okay? Which portion of the brain is becoming ischemic? Now, moving on to hemorrhagic strokes, this is what we just kind of talked about for the most part. A vessel inside the head snapped, broke, okay? And that's an intracerebral hemorrhage, okay, the gray matter. Now, what causes this is most commonly hypertension. You can imagine that would be bad on a water hose if it's commonly at high pressure. And then also cerebral amyloid angiopathy. What does this mean? It means like Alzheimer's disease, okay? Alzheimer's disease is just misfolded proteins within the brain. So just be aware, those can cause intracerebral hemorrhage. Mainly hypertension. I want you to know that hypertension can cause intracerebral hemorrhage, okay? Now, we're going to talk about this a lot in head trauma, but a subarachnoid, so we have layers of the skull, right? We have the dura mater, it's like leather, and below that, we have our arachnoid matter. It's arachnoid, so it's like these finger-like spider projections, and then below that's the pia mater. So below the arachnoid tissue, you can end up with a hemorrhage, and it produces a predictable set of signs and symptoms. But there's different causes. Head trauma, right? A brick to the head, a ruptured aneurysm, if it's on the outside too, subarachnoid hemorrhage. And then this one's pretty common, a malformation of the atrioventricular. So you can get this like Swiss cheese looking appearance of arteries and veins that mix together and create like a ball. And as you can imagine, that's not very stable and it eventually can rupture. So just be generally aware, you can have different symptoms. Now, I will tell you, they will typically give this to you in a vignette if they want you to pick this. The patient describes the worst headache of my life. And then decreasing in symptoms, like they get worse. Makes sense, right? So yeah, it's probably your last headache because this is particularly lethal, okay? So yeah, the bleeding within cranium increases intracranial pressure and will eventually get brainstem herniation, okay? Also, I want you to know that tumors can cause the same thing. We're going to talk about neoplasia here in a minute. Now, the intracranial pressure can climb and it can remain high, so the brain becomes ischemic from lack of oxygen and blood supply. This is what I was talking about earlier, the cerebral perfusion. Typically, you want this like above 70. But when it falls below like 60, 50, they're no longer perfusing the cerebrum, right? They're no longer perfusing their brain. So there is a formula that you don't need to know that can help us predict what that is, all right? Now, I want you to know this is constantly changing. It changes whether I lean back, go forward, cough, whatever. This is constantly changing. That's kind of what we're talking about. It's fairly resilient, especially to pressure changes. Make sense? Everybody good with that? All right. So, herniation. I showed y'all that picture earlier where we can go subfalcine or uncle herniation or transcavial, whatever this scenario is. We can have different herniations or protrusion of brain tissue that will shift or displace the brain, okay? So the brainstem will eventually become depressed and the patient will lose his or her functions. We've talked about that a lot, okay? Now, some of the things that we can see in stroke are slurred speech, of course. This is, we'll talk about later. Aphasia, what is that? Aphasia with an S is speech. Good. Agnosia, so this is the loss of ability to identify objects or people, as I wrote up here. So I actually find it very interesting that the human brain can very quickly tell the difference between Jesse's face and Hunter's face, right? Or these two, you know, Cooper and Dalton, very quickly. So think about how well you can recognize someone's face versus remember their name. And what are you looking at? Very subtle differences in someone's facial features. Just minor differences, and you immediately know, oh, that's Dalton. So if you have a stroke, in some cases, you'll lose that. Another way this can happen is if I put a coin in your hand and you've had a stroke on this side of the brain or the opposite side of the brain, then you might, I know it's a coin, but you might be like, I don't know what that is. They can't identify objects or people, okay? That's agnosia. Apraxia, this is difficulty with like something that they should be able to do. Like the common example is combing your hair. We all know how to comb our hair, although I don't. But you should know how to comb your hair, and that's a common skill. And if you have apraxia, you might lose something that you would commonly be brushing your teeth, right? Things that you should normally be able to do, and they want to do them, but they can't. That's apraxia. Now, they're usually not going to throw these at you and ask you to define them, but they might tell you in the vignette. Patient was trying to brush her hair and couldn't, you know, didn't recognize her husband, right? They're telling you those are stroke symptoms. Make sense? Yeah? Okay. Now, different movements. Cooper, hemiparesis, what is that? Versus hemiplasia. Help them out, AP. Hemiparesis. Is that weakness or paralysis? Weakness. Oh, weakness. Hemiplegia, like a paraplegic, right? In a wheelchair. That is paralysis, okay? Arm drifting, facial droop, tongue deviation, okay? So we don't really use this a lot in EMS, but it's worth doing. They use it a lot in nursing, is they'll ask the patient, stick out your tongue. And you have to have muscles to do that. So oddly enough, they tend to lick the side of their wounds to where if they have a left-sided stroke, they will lick the left side of their face. So they lick their wounds. But tongue deviation, okay? So that's something to be aware of. Swallowing difficulties. Why is this a problem? Can they protect their airway if they've had a stroke sometimes? Yeah, Ashley's saying no. Sometimes they cannot, and that becomes a real big problem, okay? Ptosis. They love throwing this fancy medical word out there, but it means drooping of the eyelid, okay? So they just kind of keep one of the eyelids a little bit low, but not down, okay? And ataxia, told you, Taylor, do you know what ataxia is? No. Remember, that's lack of coordination. When you lose your ability to coordinate movement, okay? All right. Now, there's different sensory effects. They could have a headache, so that they can have the sensation of a headache, makes sense. But sudden blindness, do not memorize this. It's not even on this PowerPoint I gave y'all. But I tried drawing this and it was confusing. I just want you to know, if someone has a stroke, they could have complete right-sided eye loss, right? Complete loss of vision in the right side. They could also have complete loss of the right side of both eyes. So that would mean the inside of this eye and the outside of that eye. That's what they're showing you here, right? See where it's black? That means they can't see, okay? You could have quadrantopia. They could just lose a quadrant of their eye where they can't see in the right upper quadrant of an eye. Makes sense, right? So just be aware, you can have visual defects in a stroke. And basically what's happening is, where's the lesion at? Wherever the lesion is, that gives us a predictable set of signs and symptoms, okay? So you don't need to memorize this. It's just I tried drawing it and it was too confusing yesterday. Okay, makes sense though? You can have sudden loss of vision. Sudden unilateral paresthesia. Paresthesia is like this weird feeling, you know, have you ever fallen asleep on your arm? Yep. Right? It's like tingly and numb and stuff. They could have that. That's what paresthesia is. When your arm falls asleep and it has those weird like pins and needles, that's described as paresthesia, okay? Cognitive defects and make sure they would have decreased LOC, difficulty thinking, seizures, coma, all those make sense, okay? And they could, of course, have hypertension. Makes sense, like it's very intuitive. Now, I went to paramedic school and we learned the FAST, right? Facial asymmetry, right? Arm weakness, speech, and time as brain, right? But they had to add this whole balance and eyes thing to it due to posterior strokes. So I want you to know, be fast. So a patient that's having a posterior stroke, which is a fairly rare stroke, but they're commonly missed, is they won't have good balance, okay? And they also can have blurry vision. Well, what's bad about this is sometimes patients with hypertension can present the same way. End organ dysfunction, yeah? So they could have balance and eye disturbances, so these are commonly missed. That's why they added this on here. But these are still strokes, okay? So you have to know, be fast. Very, very, very important to recognize it. Loss of balance acutely and blurred vision, that could mean a stroke. Everybody good with that? Good? And I said it's a posterior stroke. Well, what's on the back of the head?
Occipital.
Occipital, which has to do with vision. Yeah, see? Yeah? So, that's one. Now, yeah, so beginning standard cares, EKG. You might be able to draw labs if you work for a system that does that. You know, they're saying that this could be confused with sepsis. I don't want you to really focus in on that, but allow patient to remain supine unless hypoxic. There's a reason for this, and I'm just mentioning it because it's here, so it might be on a quiz or something, I don't know. But the idea is when you sit up, you have to increase intracranial pressure to keep perfusing, right? So if you're laying flat, your brain doesn't have to work as hard to perfuse. That's kind of the idea on that. Now, someone's hypoxic, short of breath, at risk of aspiration, that changes things. Makes sense, right? So why am I telling you this? If a patient lays flat, like on the CT table, sometimes they'll get better, right? Waxing and waning of symptoms, so just be remotely aware of that. Now, this is what my paper that I wrote was all about, but it's talking about, well, if you have this set of signs and symptoms, what hospital do you transport to? Very difficult decision. Do you go there or do you go to Harristown Town? Very difficult. So, I'll give you some quick examples. An acute stroke ready hospital would be like Palo Pinto General, Azle, right? These are relatively small hospitals that carry the clot busting drug TPA, okay? So they do some stroke training, but they're not great, but they do enough. Primary stroke centers are like Weatherford. Primary means the first, so you could go there first. They carry TPA, they have access to a neurology team, okay? On telemed usually. And then this bottom one, this one's new, but this bottom one is comprehensive. So if I give you a comprehensive final exam, what does that mean? Everything. So they do all the stroke care. That's JPS, Harristown Town. Not even Bailey, but Medical City Fort Worth, okay? They do it all. It's a one-stop shop. So let me give you an example. You have a lady that, you know, 2 days ago she fell in the bathtub and now she's presenting with stroke symptoms. She hit her head 2 days ago. Are you going to take her to Weatherford or probably to Harristown Town? Harristown Town, because she needs to have neurosurgery, right? Now, you have a lady that, you know, at the post office developed sudden stroke symptoms Post office is right there. Are you going to go to Weatherford or Harris Downtown? You might want to go to Weatherford first, okay? There's different patterns and discussions on that. Very complicated, but that's where we're at, okay? Just be generally aware of those, okay? This last one I need to talk about. The thrombectomy capable stroke center. So thrombectomy is where they go through an artery or vein and they will literally go grab that clot and pull it out. Okay, science fiction is very cool. So a neurologist, neurosurgeon goes in there like a cath lab and they will go up to that lesion and yank it out of there and stent it. Okay, pretty cool. Okay, so yeah. Now it's funny, they said lay the patient supine, and then on the next slide they say you might elevate the patient's head around 30 degrees. What they're saying is you don't necessarily need them sitting straight up, okay? Now, ensure the airway is clear, watch for seizures. These are the patients that I told you. I like to take the suction, unplug it, and just put it behind the patient's head underneath the pillow. That way it's just ready. I just don't want, I hate digging for suction when you need it, okay? Time essential, so I used to know the number, but it's in the millions of neurons that die every minute in the case of a stroke. Millions, okay? It's huge. So time is brain. So this is not the one where you're trying 8 times on scene to get a 24 gauge in the hand. Transport them. Go to the hospital. You are not helping them by staying on scene. You should be on scene as little as possible and just go. Get out of there. Take them to the hospital. This is what I was talking about earlier, and I'm willing to bet they're going to ask you something like this in the future. But high CO2 levels cause dilation of the cerebral arteries. Okay? So, to counter that, low CO2, hyperventilation, causes constriction, right? That's what I was talking about with the therapeutic hyperventilation. It causes constriction, okay? So there is this little balance that you have to play. So you might try to keep their end tidal, not at 25, but between, instead of 35 to 45, 30 to 35. So just on the lower end. Make sense? Okay? So, you know, when you're working a vent or bagging the patient, you might work for a service where they still encourage this. This was really popular, then it went away, and I feel like it's getting popular again because paramedics took it a little too literal and were bagging people like 80 times a minute. You know, it's like, what are you doing? I got their end tidal down to 10. You know, shout out me, right? But you probably also killed them. So just be aware that the goal is not an end tidal of 15. The goal is an end tidal of 30 to 35. It's not that low. Okay? That's confusing. I don't want to talk about it. It's not important. So let me say this. The single most important information that we can get from the scene of a stroke is their last known well. Okay? Now, confusing scenario. Patient went to bed at 9 p.m. You get a call at 5:50 in the morning. Now they have stroke symptoms. What's their last known well?
Whenever they were last
the last time you saw them. That is heartbreaking because what is the window of TPA? 3 to 4.5, depends on who you ask. I think it is 4.5 now with the FDA. I think it's finally been increased, but I don't know that for sure. But most hospitals are doing like 4.5, okay? So that patient's not a TPA candidate usually. Pretty sad, right? So the last known well is the last time they were seen well.
But it doesn't mean not to still move in alacrity because there's now 24-hour.
Correct. So, okay, so remember thrombectomy where you can go in there and grab the clot? That can be up to 24 hours. I did some research with that too. It's called the Dawn trial, and basically they can go in there and they can go yank that clot out up to 24 hours. They found that the risk was worth the reward, okay? It's called the Dawn trial. You can read about it. So very cool.
If you're like outside the window, would you go ahead and go to like a comprehensive stroke center?
That's where it gets very complicated. Yeah, you would. If you're, you have to, yeah, let's just say yeah.
You know they're not
if you know they're not a TPA candidate, you could just go ahead and go to a comprehensive stroke center because their only hope at that point would be thrombectomy. Now, if you know if they've had extensive bleeding, you know, like, or say they had abdominal surgery and they're on blood thinners and all this weird stuff, yeah, I guess you still want to go to comprehensive. The idea is though you don't want to overrun comprehensive stroke centers with non-viable patients. Okay, so that's kind of where the argument comes into play. And some people will say no, some people will say yes. There's still a lot of research to be done on that. But yeah, generally, I would say just take them to a stroke center, to a comprehensive footwork, because that's their only hope is thrombectomy if they're going to get it. Yes?
After they have a thrombectomy, do they go like back to normal, or is it
they can.
After
it's incredible.
Hours, is damage already done?
Yeah, they can. And what you're hoping for is you may not get 100% resolution. They use this thing called the Rankin scale. But you might get some resolution to where maybe they can use the right arm now, but their left leg's still shot. You know, who knows? So the idea is maybe you'll get a little bit better, okay? It's an important concept to know. The central nervous system does not regenerate ever. When you jack up your brain or spinal cord, that's it. Okay? Now, peripheral nerves do regenerate. When you cut your finger, you don't just lose sensation on the tip of your finger for the rest of your life, right? Those do regenerate, which is kind of interesting. Okay? Now, yeah, so the most important thing we can get on scene is last known well and medication history. Okay? So we need to know if they're taking blood thinners. The hospital needs to know that. A patient on like Eliquis, right? Well, not Wellbutrin, warfarin, stuff like that, they can't have TPA. So they need to know, are they on these medications? Did they take them? They also need to know things like, have they had surgery? Do they have a history of bleeding? Have they had a GI bleed? There's all these different things that they have to look at in different timelines and algorithms they work through. But just be generally aware. That's what they're talking about, fibrinolytic checklist, okay? Now, these things, they don't work. The research proves it. But, I mean, but I'm just letting you know they're still talking about it. So, yeah, transport these patients. And, you know, I'm not the guy that's saying transport everyone lights and sirens, but these tend to be fairly emergent patients, okay? You kind of, I mean, time truly is brain on these patients. And if you don't want to transport lights and sirens, that's fine. But don't spend 45 minutes on scene getting IVs and 12 leads and stuff like that. They don't matter. Go to the hospital. Do it en route. If you can't get it en route, don't worry about it. Just keep going. Go to the hospital. We lose track of that sometimes as paramedics. We lose track of time, and we get so mission oriented. Gotta get an IV, gotta get an IV, gotta get an IV. And you look up and you're like, shit, I've been on scene 35 minutes. Just go. Get out of there. Start transporting. Okay? Now, let's talk about TIAs, or transient ischemic attack. So it's episodes of cerebral ischemia without permanent damage, and the definition on this varies so widely, but let's just use the book's definition. It's episodes that can resolve within an hour. Some places say 24 hours, some places say, you know, a few hours, 4 hours, but your book is saying an hour, so let's just use that. Everybody good with that? It's stroke symptoms that come and go within an hour, okay? So it means that there's sign of a vascular problem. In fact, 80% of TIAs, they will have a full-blown stroke within 1 week if they are not intervened. So this is your warning sign. 80%, so 8 out of 10 patients that present with a TIA, if you AMA them and leave them at home, they're going to have a full-blown stroke within a week. So it's very important that these patients still go to the hospital. Let me tell you this too. In this first hour that we typically see patients, is it easy to tell the difference between a TIA or a stroke? No, it's impossible. It doesn't matter if you're a neurologist, okay? You can't tell the difference. So don't be big shot paramedic thinking the one slide in paramedic school qualified me to tell the difference between a TIA and a stroke. Makes sense? It's a stroke is a stroke is a stroke. You take them to the hospital. I also want to point something out, that there is a difference between a TIA and waxing and waning of symptoms. Y'all know the moon cycle, waxing and waning, that comes and goes? Same thing happens with stroke symptoms. Just like chest pain gets a little better, a little worse, same thing happens to your brain, okay? So just be aware, symptoms can get better and worse with a stroke patient. Makes sense, right? All right. So yeah, don't get hung up on trying to diagnose. I've seen paramedics do this at Life Care, where they're trying to like diagnose TIAs and stuff. Dangerous, dangerous business. That is a neurologist's job. That is a physician's job. And it's very risky business to be blowing off TIAs. They have to go to the hospital, okay? Yeah, so transport those patients, and that's it on stroke. Any questions on stroke? We good with that? Okay. Now let's talk about coma. I don't even want to go through these. They're annoying. You can read them on your own, but it's AEIOU tips mnemonic. So like alcohol, acidosis, epilepsy, endocrine, electrolytes, insulin, opiates, uremia, trauma, temp, infection, poisoning. Pretty much everything under the sun can cause coma. What is the definition of coma? Coma is a decrease in the level of consciousness. Okay? When I think coma, I typically think of someone completely unresponsive, but it is defined as just a decrease in level of consciousness. Makes sense? Yeah, so yeah, you would want to know when the patient was last normal, of course, similar to a stroke, and how quickly did they become unconscious? Did this happen over a period of days, or did it happen in about 2 seconds? You know, that could help us diagnose, okay? Now, they could have different cognitive effects, you know, like decreasing OC, confusion, hallucinations, delusions, psychosis, difficulty thinking, sleepiness, drowsiness, right? Or they could just be totally unresponsive. This is 10 to what I think we get called right about here typically, right? So they're totally unresponsive. Again, different speech defects, agnosia, right? So the inability to identify objects, apraxia, inability to do learned or known tasks when you want to do them, aphasia with an S, lack of speech, normal speech, Ataxia, lack of coordination. Aphasia, this is wrong. I was supposed to fix this too. I was talking to people in my office when I did this part. This is inability to swallow. I'm spelling that wrong.
What is the inability to write called?
It's dyspraxia. Is that not on there?
No.
Yeah, it's dyspraxia. Okay. So yeah, dyspraxia. But aphasia with a G, gulp, is swallow. So they sound very similar to each other, but just be aware of that, okay? Now seizures, posturing, okay? Posturing, that thing. I think that's too confusing, so I don't like using that. So we could look for drug paraphernalia, of course, an overdose could cause, so we gotta, coma is very difficult to diagnose, right? You're kind of starting at the ground, working backwards on these, they're difficult. And if you're gonna be able to reverse it, you have to gather some good information on scene. You have to play detective. And, do the ER physicians or nurses get to gather that information? No, you're gathering that information. So do be aware of your surroundings and try to gather what you can and bring that to the ER so they can hopefully put together some of those pieces. Make sense? Yeah? All right. Now, that's it for coma. Any questions on coma? Good. Let's talk about seizures. This is out of my book, my medical school book, the first aid book. But there's some different types of seizures. And I notice in paramedic education, they tend to get pretty granular on this. This is one of the things where they really want you to know the differences between different seizures because the treatment changes, okay? So I would actually say everything on here is actually fair game. So you do want to know this, okay? So let's just start up here at the top. A partial seizure is also called a focal seizure. What's a foci?
One.
Yeah, it's like a single area that's concentrated. So if we have a single area of my brain that's seizing, it'll present a predictable pattern based on where it's at in a limited area. So I might just have a single arm that's just flailing, right? Makes sense, right? It's just one area, focal, or a partial part of my brain that is seizing, okay? So it affects just a single area of the brain. And the difference between a simple partial or a complex partial is just consciousness. So if I'm sitting here and saying, oh wow, I think I'm having a seizure, that would be a simple partial seizure. But if I'm unconscious and just my right arm is flailing, that is a complex partial. So that's the nomenclature there. Complex means they've lost their ability, their consciousness, okay? Now, moving forward to generalized seizures, we tend to think of tonic-clonic seizures or grand mal seizures, right? This is what we've seen, and there's different stages to this. Has anyone seen a real seizure in life? Right? So the tonic part is when they stretch out, they might even make a little bit of a scream or a yell, and then they start flailing. That's the clonic part, okay? So tonic, stiffening, they might even stiffen their back, and then the myoclonic part is when they start shaking. Now, a word too that you might know is atonic. A without tone, so they just fall to the floor, okay? They lose their muscle tone and they just fall down. That's atonic, okay? Now, how do we treat this? It's on your exam. How do we treat grand mal seizures that have lasted more than 2 minutes? Good. Well, very good. What's the dose? Oh shit! That's the question on your exam. It's 2.5 milligrams. Write it down. It's 2.5 milligrams of midazolam.
In pediatrics, like 0.3 to 0.5.
I don't even know the dose anymore.
Pediatrics is whatever the Brosologic says on which side.
That is the treatment of grand mal seizures, okay? Now, there's this last one called an absent seizure. Yeah, so an absent seizure is typically a kid. And what, Amy?
Never mind.
No, go ahead, Jesse.
I didn't hear how long you waited to give that.
So typically some will say 5 minutes of seizing. Or status epilepticus, which I'll take a step back. Status epilepticus is a seizure that lasts more than 5 minutes or without a gain of a lucid interval, right? That's a standard definition. So someone that seizes for more than 5 minutes, or they have recurring seizures where they never are lucid, okay? That's called status epilepticus, and we're going to cover each of these very quickly coming up in the slides, okay? So, back to an absent seizure. The classical vignette for an absent seizure is a kid sitting in class that is staring off into space. They can also do lip smacking or eye fluttering. Okay, so they could just sit there and be staring off, and they'll describe that to you, and that is an absent seizure. Okay, they tend to not last very long, about 10 seconds, and you can actually trigger it by asking the kid to hyperventilate. But just be generally aware of an absent seizure. So again, the classical vignette on this: kid sitting in class that is staring off into space, absent seizure. Okay, now good. Let's talk about this. What is a seizure itself? It is unorganized electrical firing across the brain. Makes sense, right? So just imagine arcing all across the brain. Does that take energy?
Yes.
It takes a tremendous amount of energy. How do we make energy? ATP, how do we make it? Glucose and oxygen, okay? So what happens is the glucose and oxygen stores are rapidly depleted. Now, thankfully, we have this thing called glycogen that'll stir up some glucose from your liver, and so you're usually fine on glucose after a seizure. But what you're usually not fine on is oxygen. Let me ask you this. Someone having a tonic-clonic seizure, are they breathing effectively?
No.
No. Their diaphragm is not allowing you to breathe in, breathe out. So when you lose that, on top of moving all your muscles at once, on top of your brain firing chaotically, are you hypoxic?
Yes.
99 times out of 100, yes, okay? So what do we do for seizure patients? We correct hypoxia. We give them oxygen, okay? So I always would slap a non-breather on a seizure patient, especially a postictal patient. They are hypoxic. They are hypoxic, okay? So put a non-breather on them and give them some oxygen, okay? And you can even do this on an actively seizing patient a lot of times. You can slap a non-breather on them, give them blow-by if you have enough hands. So, yeah, serious long-term effects including death. That would make sense if your brain burns out. Now, there's different causes of this, right? Abscesses, alcohol, withdrawal from alcohol, okay? Delirium tremens, which, yeah, we don't have time, but anyways, brain infections, brain trauma, diabetes, fever, idiopathic. Sometimes you just don't know why. There's no known cause, it just happens, yes?
I've heard like the term pseudo seizure.
Coming up, I got you. It's coming up, we're gonna talk about that, okay? Tumor, okay? Lots of different causes. Now, I also want you to know that straight up low blood sugar will cause a seizure, okay? And as you can imagine, if there's not enough glucose in there, things can start going haywire and start firing in an unorganized fashion, okay? Makes sense. So there's different classifications. This is, again, as paramedics, where our report becomes really important to say, hey, they went tonic, they got real stiff, she screamed out, and then she seized for about 90 seconds, and then she stopped and she was postictal for 40 seconds, or for, I don't know, 4 minutes. You know what I'm saying? Giving that report's really important instead of saying, yeah, she had a big seizure. So you want to hand this off and be organized in your report with what you're handing off, okay? They need to know, was it just the right arm? Was it the right arm and the right leg? Was it only the arms? Was it only the legs? Okay? These are all things that are important, okay? The patient's level of consciousness and awareness. This is the difference between simple and complex seizures. We've got to know the difference between the two, okay? Okay, and I want to talk about, so yeah, this is on your exam. In fact, they use the word diazepam, not midazolam. Does anybody know the name brand of diazepam? It's Valium. Your book's obsessed with diazepam, but here's what the cool part. The dose of midazolam and diazepam are the same. They're the same. Okay? So 2.5 of Versed means 2.5 of Valium.
Say that doesn't touch it.
It's a good question.
Say it doesn't work.
So just like when I bake my cookies, I can put a little salt and sugar in there, but I can't ever get it back. So you always want to start with a little bit, and if they continue to seize, cool, you got an IV, you give them some more. Wait.
Another 2.5?
Yeah, I would usually do it in 2.5 increments.
Okay.
Now there are some systems that'll just straight up give them 5 or 10. I'm not the medical director, but I'm just telling you that I've intubated patients where we gave a guy 5 milligrams of Versed once, and he stopped breathing. So let me ask you, so we ended up RSIing them. This is a good discussion. We RSI them. How do I know? Because in RSI, we take away their muscular tone, so they're no longer shaking, but does that mean there's not electricity firing across their brain in an unorganized fashion? No, it doesn't mean that necessarily stops. So what's one of our assessment tools we can use? How do we know if a paralyzed patient is still seizing?
Is it eyeball?
What? It's their eyes. Their eyes will bounce. Sometimes, not always. But pretty much the only tool you have is to see, are their eyes bouncing up in their skull, right, in an unorganized fashion? That might mean that they are still, that they're still seizing, okay? That doesn't always happen, you can't hang your hat on it, but it's worth a quick peek with a seizing patient to open up their eyes, look at both of them. Are they bouncing all over the place? They may be seizing. Make sense, everyone? Yeah? What?
Do you still go through with, if they're still seizing like that, do you just give them more Versed?
Give them more Versed. And now that they're intubated, who cares if they quit breathing? You're breathing for them. Make sense? Okay? So people miss this, and you're going to burn up their brain if you let them keep seizing and not catch that. Okay? So yeah, they talk about the loss of consciousness, the tonic phase, that's the stiffening tone tonic, right? Tonic phase. The clonic phase, this is the rhythmic jerking. Post-seizure phase and the postictal phase. Postictal phase is how that's pronounced. Now this is after the seizure. This is the people that we run into Walmart and they're kind of confused and combative. Now, why are they confused and combative? They just ran a marathon without enough oxygen. They're hypoxic. Okay, so that is the predictable side of hypoxia: confusion, aggression, irritability. Okay. Now, this is the absent seizure. I talked about this. I'm not going to spend much time on this, but I want you to know: fluttering of the eyes, lips smacking in a kid, child staring off into space, probably an absent seizure. Okay. They might even be talking and walking in mid-action, just start blinking, and that could mean an absent seizure. These only last about 10 to 15 seconds usually. Everyone good with that? Mm-hmm. Do we treat this patient with Versed?
No.
No, we do not.
That's something they just grow out of.
Typically, yeah. So focal seizures, remember, these only affect one side of the brain or one spot in the brain, but it's not the whole brain like a generalized seizure or grand mal seizure, okay? So patient is unable to talk or respond, or their awareness will remain intact. So what does that mean? They may not be able to talk to you like we're talking, but they are aware of what's happening. Does that make sense? So just because they can't talk doesn't mean that they're not aware. So don't get hung up on that. They should last less than 2 minutes. I actually ran a guy that was doing that once. He was sitting there and he talked to me all the way to Harris from Peaster. And he would just, for about it was less than 2 seconds, about a minute, he would just start doing it. And I called our medical director at the time and I said, do you want me to give him Versed? And he said no. So we didn't. So we just took him emergently to Harris. So just be aware that these actually do happen. I will say, generally, when we get called, they're full-blown grand mal seizures, as you can imagine. Okay? We're about to talk about pseudo seizures right now. Yeah. So pseudo, what does pseudo mean?
Fake.
Fake. It actually means fake. Okay? Or kind of like not real. Might be a little bit more, I don't know, PC word. But these are from psychiatric origin. Okay? So the patient could be making this up because they're triggered by emotional events, stress, light, pain, whatever. But I'll tell you there's a pattern to this. It occurs with witnesses. Mm-hmm. It's not cool to fake seizures by yourself. Okay? It's not very rewarding. You're not going to get attention that way or fulfill whatever psychiatric condition you're wanting. So these are the people, they will almost always be in class or at the family reunion or at the Walmart or something like that. Okay? Now, the motion will be relatively organized, and they typically won't have incontinence. What's incontinence, Corinne?
Pee. You lose control of your bowel.
Lose control of your bowel. Pee or poop, right? So they typically won't, but I'm not saying they couldn't. Now, here's my spiel on this. It is better to go ahead and just treat these patients if they're putting on the full tonic-clonic thing and you are questioning, man, is this real or not? You need to treat them, okay? If there's beyond a shadow of a doubt, you need to treat them even if you think it might be a pseudo seizure. It is a lot easier to treat something, right, than to not treat it. Do no harm. Could you potentially cause harm allowing someone to have a grand mal seizure and not intervening when you have the tools to intervene versus intervening on someone who's faking the seizure?
Yeah.
Right, you're going to cause harm if you don't intervene on the real seizure. So my thing is, I see paramedics get a little too excited about, oh, this is a pseudo seizure, look, look, look. And they'll do all these crazy barbaric tests like dropping the hand on the patient's head or eliciting pain or something like that. You're better off just to treat the patient. So what do we do in EMS? We treat seizures. We're not neurologists. We're not trying to diagnose the difference between a temporal seizure, a pseudo seizure, a simple complex, you know. If it's a seizure and you think it needs to be treated per your protocol guidelines, whether it says they're having tonic-clonic motion for more than 2 to 5 minutes, or you know, no lucid interval or whatever the protocol says, you treat it. We treat seizures. Everybody good with that? Don't get hung up on this. This is what terrible, cruel, burnt out paramedics do. They think they know more than the world and they try not to treat stuff. So again, if you have, now with that, if the patient tells you they have a history of pseudo seizures and they're on their 5th seizure of the day, maybe in that case you don't. I've had patients report to me, I have pseudo seizures. And I'm thinking to myself, I guess you've never looked this up. But they do. They will tell you, I have a history of pseudo seizures. So so in that case, maybe I won't be so quick to treat them. But I walk into the, you know, to the nasty, gingy trailer and the guy's having a seizure and I'm thinking, maybe it's real, maybe it's not. It's real until, I'm not going to prove it's not. So you treat it.
Are you going to give them Versed?
Yeah.
Yeah.
Yeah, I will.
What is the
Now, I have seen people, you know, they'll be seizing. I think I ran a call with Jeff once doing this. The lady was seizing, and then we're like, oh man, I wish you would hold her right arm straight. She's like, continues seizing, she's holding her right arm straight. So we started an IV, and you know, she stopped, but
She gave me your arm to start the idea.
that's what it was. That's what it was. And she just like plopped or something, but
She's still alive.
Did y'all laugh?
I don't remember.
I don't think so.
I think we just looked at each other like, well, that solved that problem. But I'm just being generally, sometimes it's painfully obvious, but some of these people, they go to town. They'll pee and poop on themselves, they'll bite themselves, they'll froth at their mouth or whatever. Just, if you have a doubt, you treat it. Everybody good with that? I don't want to spend much more time on it.
The 10 mils of normal saline.
Well, you gotta be careful doing that, yeah. Did y'all hear when we said you could give 10 milliliters of normal saline? That's a placebo. And remember from pharmacology, placebos are never the answer. Alright?
Or ammonia tablets?
It says that you give it to them, they're like, oh, it fixed.
Yeah, or what I like to do is, you know, what is accurate is like, oh, okay, I'm gonna put oxygen on you, it might make you feel better. And that's not a placebo, it is a true intervention. But you can't call it noraceline when it's normal saline. Like that's unethical, okay? So I'm just letting you know, you really can't do that. It's
Do
unethical.
you use like an ammonia tablet?
I have never worked in a system that carries those, so I would not recommend. I've seen barbaric things with ammonia tablets. I've seen them crack 3 of them and put it in a non-breather.
Oh,
That's assault, brother. Okay, you can't do that.
damn.
But
We
I know y'all do.
We did too.
That's where I saw it. So that was a decade ago. But yes, that's where I saw it.
Hey Hunter.
Yes.
What's the dosage for like intranasal?
Okay, guys, hang with me. We're about to take a break. So let's talk. He asked, what's the dose for intranasal? You'll know we can give Versed intranasally. It usually starts off around 5 milligrams. Typically, you double your IV dose.
Okay.
Typically, some places, sometimes you'll triple it. But I'd probably start at 5 myself.
Does National Registry recognize intranasal? Probably. They do.
Mhm.
Okay.
They're not going to twist your arm though and make you give intranasal Versed though.
Okay.
Yeah, they're not going to mess with you and be like, you can't get an IV. Like we might mess with you in scenarios and say, you can't get an IV, now what?
Yeah.
They typically aren't going to do that. Remember, National Registry gives you the prototypical, stereotypical patient. They do that. They want the prototypical, stereotypical, national, not Texas, not Parker County, not Weatherford, but the national treatment for it. Someone raise their hand, yes?
So they're flopping around like fish, can't get an IV. Would you go intranasal or would you rescue it? I mean, which would you
I preferred intranasal. I didn't like getting a needle next to a bouncing patient. You know what I'm saying? To where I could usually get intranasal a lot more comfortably, and if I spray a little out, who cares? Versus a dirty needle now, and I'm pulling it out, you know, because once you go in and you come out, that is a dirty needle. You know what I'm saying? So it just wasn't my go-to. I have done IM Versed before. It just wasn't my flavor. If I was going to try to poke someone, I'd probably go for an IV or just do straight up intranasal. But let me tell you this. Giving Versed to a seizure patient in the pre-hospital environment is exceptionally rare. Exceptionally rare. By the time you get all the shit out, they're usually done. You know what I'm saying? Like, it's pretty rare for someone to seize that long. Now, I've had a patient before. She seized for 35 minutes prior to us getting there. She had just had a tumor removed. So be aware, that can happen. We ended up RSIing her. But I'm just letting you know, it doesn't happen as much as you would think. Okay? We're almost done with seizures, then we're taking a break, okay? So, all patients should be transported, provide emotional support. The patient's going to wake up confused. Now, what is a febrile seizure, Dylan? Febrile seizure.
Seizure is caused by temperature.
Yeah, a fever seizure. Who does that typically happen in, actually?
Kids.
Children, right? Children have febrile seizures. Now, it's not necessarily the level. It doesn't matter if they got up to 105. It's how quick they got there, okay? So, do we treat this with Versed?
No.
Typically not. No, the answer is no. They're seizing for 10 minutes. Do we treat it with Versed even though they have a fever? Yes, okay? But typically, they're benign, they're self-limiting. Now, let me tell you this. Worked at Cook Children's for 2.5 years. We used to have patients come in and sitting in our waiting room for 30 hours, 3-0. I get mad waiting 30 minutes for a table. Imagine waiting 30 hours to see a doctor. 30 hours in our waiting room, and their child had febrile seizures. That's fine. It's not a neurological emergency, but that doesn't mean we AMA these patients. That doesn't mean we don't transport them. There is still a condition that can be stopped or slowed, a bacterial or viral infection. They still need to see a physician. And I've seen paramedics say, call your pediatrician tomorrow. Yeah, the pediatrician will see them in 6 weeks. You know what I'm saying? They're not going to see you the next day. These patients still need to be transported. They still need to go to the hospital. Do you need to go to the hospital, lights and sirens, and be freaking out? No. Are they going to go to a waiting room? Perhaps, depends on the census. But that's not your problem, okay? We're in the ambulance business. We take people to the hospital. So it is unethical, inappropriate, wrong to try to AMA a febrile seizure. They need to be seen. There is either a fever, there is a fever that is so severe their child seized, okay? If you were not in this field and you saw your child seized, would you be happy?
No.
You're going to be scared. So the paramedic coming in there, which they trust you and you convincing them it's fine, call your pediatrician tomorrow, that's wrong. That is negligence. That is practicing medicine without a license, okay? So these patients still go to the hospital. Everybody good with that? I think we're all on the same page there. All patients should be transported. We do not encourage people to AMA. Let me tell you this, same thing with epileptic patients. If they're on epilepsy medicine and it has failed them and they are now having seizures, do they need to see someone?
Yes.
Yes. What happens when they're walking and they fall and crack their head on the curb?
JPS.
Right? No, I'm saying, yeah, but what happens on the next seizure when they crack their head open? You know what I'm saying? They need to be transported. They need to go to the hospital. Do they have to go lights and sirens? No. Are they going to go to a waiting room? Perhaps. But guess what if they have another seizure? They're in a freaking hospital. Okay? They'll take care of it. Yes.
What if they just don't want to go?
That's their right. Patients have the right to refuse, but they have a right to informed consent. They have a right to informed refusal. They have the right to know that I am encouraging you. It would be against medical advice. You could have serious injury, including up to great bodily injury or harm, death, by refusing to go to the hospital. And then you go and explain it to them in layman's terms. There's something going on in your brain that is causing this to happen, and it is probably preventable. What's going to happen next time when you're driving, or when you're walking, or when you're home alone and you have a seizure and you crack your head in the bathtub? You know what I'm saying? Like, when you start explaining those things. Now, I have had patients that AMA'd and they're like, nope, my mom's going to drive me. My daughter's going to drive me, or something like that. You know, that's their right, but it's not what we're going to encourage as EMS, especially in academic EMS. That's not what we're going to encourage. Okay?
What if they're still like in their postdoctoral stage?
They don't have the right of refusal.
They don't?
No.
And even if they're saying no?
So someone's no, right? Where are you at? What's going on?
If they can't answer your questions.
Yeah. So you don't necessarily have to establish, are they alert going in times 4? You have to establish, are they aware of the risk of refusal? Okay? We're getting into ethics and law, but basically someone can refuse an ambulance service and not necessarily know today's date. But if they're aware of what the risk of refusal, and they have informed consent, informed refusal, then yeah, they could refuse. Now, same thing. You could have someone in a nursing home. You know, what if they are A&O times 4, but they aren't aware of the risk of refusal? So what I'm saying, where I'm getting at with this is, I see paramedic students paramedics get real hung up on this whole, nope, they're A&O times 4, but they're suicidal, so they can refuse. No. Are they aware of the risk of refusal? Like, are they aware, informed refusal, informed consent? Make sense? Don't hang your hat on that whole, they're alert, they know the president for the last 8 years, right? When I was doing it, Obama was in office for 8 years. Does that really tell you what's happening in a current event? No. Who's the governor? Greg Abbott's been in office for 12, 16 years now, right? Do you know what I'm saying? So, that's a silly question. AP, what's today? What is today? Don't look. What's today? What's the month? What's the day?
Oh. Don't ask that anymore.
It's the 7th.
Thursday. It's Thursday.
Oh, it is the 8th. I don't even know what day it is, but you know what I'm saying?
Don't ask that shit.
Knowing the date doesn't necessarily prove consent or knowledge, right? You know, that's just what I'm saying. How many quarters are in a dollar? Knowing that or not, does that mean that you have the knowledge of refusing medical care? You know what I'm saying? I just think that paramedics hang their hat on that way too much. So, are there tools in your toolbox, but they're not exclusive, they're not entire. Okay? We're almost done with seizures, and then we're going to take a break. I know we need a break, and then we're going to finish this bad boy up. Now, differentiating seizure from stroke, I found this weird. I don't think that they present similarly. I have no clue why this is even I don't know how you confuse the two, so we're not going to talk about it. Now, I talked to this too. I do encourage you, they do this in the hospital, try to pad the cots and the rails. You'll notice that most Stryker stretchers don't have rails that go up near the head. It's by design. But, you know, keep the patient from banging their head. Do we strap down patients as tight as we can get them? Do we put stuff on top of the patient? No. Okay, yeah, good. So yeah, you don't want them necessarily to be too tight. So notice the PAMs and the LAMs, but these are all our benzodiazepines, okay? Does anybody know the trade name for lorazepam? Yeah, it's Ativan. Ativan, and it's commonly carried on ambulance. These are all very commonly carried. Valium, Ativan, Versed. Okay? And this one has a different dosing. Okay, almost done, guys. Status epilepticus, it's a seizure of more than 4 or 5 minutes. You can present with neurons being damaged or killed. We have to stop those seizures. Those are the seizures where you're doing intranasal Versed, IM, or you're taking an arm out and holding it to try to get an IV, an EJ, I don't know. You got to do something. You have to stop these patients. Stop them, okay? It is particularly lethal if we do not intervene. So, and even your book goes as far as saying you can check for implanted IV access ports. You know, this is lethal. So this may be the time where you do end up using a port or a fistula or a shunt or something to that effect. Okay. Yeah, and this is what they're talking about, and I told y'all about this, right? So you might have to control their airway and ventilation. Have y'all ever seen a patient that was seizing that had already vomited?
Yeah.
That happens sometimes. So does that patient need to be intubated?
Yeah.
Likely, eventually, they're going to need to be intubated. There's a freaking vomit in their mouth, and they're seizing. Are you protecting your airway while you're seizing? No, you lose muscle tone and control. So yeah, okay. Pregnant patients, we treat it with magnesium. Dylan, what's it called when a pregnant patient seizes? Eclampsia. It's no longer preeclampsia. The minute they start seizing, we drop the pre. It's full-blown eclampsia. Okay? Everybody good with that? The antidote, magnesium. What if magnesium doesn't work? Then you go to Versed. Make sense? Okay? You would want to hold off on Versed, though magnesium will probably work. But it also causes harm to the fetus with a seizing mom. Makes sense, right? Hypoxia. Okay? Probably more harm than Versed would cause. Yeah, I don't have... Oh, that's it. Let's take a break. Let's come back at 3:25. That's in 11 minutes. Everybody good with that?
Yes.
All right, let's do it.
So